This presentation concerns ventilation using a bag valve mask and ventilating to advanced airways. The goal of our ventilation is to deliver oxygen to the alveoli. We talked in a previous presentation about the necessity to have oxygen for cells in order for cells to be able to do what cells are supposed to do. And so in order for us to deliver sufficient air with oxygen to patients, in many cases we need to ventilate them. Simply placing them on supplemental oxygen will not move air sufficiently to the bottom of the bronchial tree, to the alveoli. And so positive pressure ventilation is necessary. The other benefit of ventilation is not just the delivery of oxygen, but the removal of carbon dioxide, and that it's nearly as important, I would say, as the delivery of oxygen. Oxygen can make its way to the alveoli without ventilation, but carbon dioxide will not move in and out without the convection of air. So ventilation is important for those two reasons. And then this concept of dead space. Dead space is essentially the areas in the airway that do not mix with blood. So there's no oxygen and carbon dioxide exchange with the bloodstream. So the upper airways, the trachea, the bronchioles, most of the bronchial tree, the trunk of the tree in essence, does not exchange blood and oxygen. In order to get oxygen exchange and carbon dioxide moving in and out, we do have to ventilate the entire bronchial tree. Three critical pieces of ventilation technique: proper pressure, proper volume, and the proper rate. We'll talk about those as we move through the next couple of screens. Proper pressure is key to keep the amount of air that enters the stomach to a minimum. Anytime we do positive pressure ventilation, there's going to be some air that doesn't make it into the trachea, makes it down the esophagus and into the stomach. That's inevitable. Our goal is to limit that because we cannot eliminate it. Obviously, air in the stomach produces gastric insufflation, gastric distension, which makes emesis more likely. Vomiting equals a likelihood of aspiration, where the vomit is inspired into the lung tissue, and aspiration will simply add to the likelihood of a poor outcome for our patients. So we must control our pressure, smooth, low-pressure ventilations with the correct volume. The correct volume would be enough to make the chest rise, not the entire volume of the bag valve mask or the most that we can squeeze in. You'll see some of these smart bags, they're called, bag valve mask, moving into practice very soon. They're visually different from our current Ambu spurs in that the smart bag is red. What the smart bag does is it helps you get proper pressure. It keeps you from exerting too much pressure. Now there's pop-off valves on the Ambu spurs, and that's a different thing. That is when volume has become a problem, but the smart bag really helps you to give a smooth, low-pressure ventilation. And once you have one in your hand and you play with it a couple of times, it's very intuitive and becomes immediately obvious how it works. So we believe these are an excellent tool. We'll be deploying those soon. And you can see in the picture on the bottom right, there is a switch where you can flip disable the pressure valve and go back to a plain non-smart bag. But we think these are an excellent tool to help us with proper ventilation pressures. Ventilation volume, again, only until they get a normal chest rise. It is not important to empty the entire bag valve mask. It is important to get a normal chest rise, not a maximal chest rise. Most adults, even large adults, will only need about a third to one-half the volume of that adult bag valve mask. The adult bag valve mask holds 1,500 cc's, and even a 100-kilogram person is only going to need about half of that. So a 220, 250-pound patient is only going to really need about half of the volume of that bag. In years past, we have ventilated too rapidly, too often, and definitely we've overventilated in terms of volume. These are the new standards. American Heart supports this. The current industry literature is full of this sort of stuff, and we really need to focus on making the switch to proper volume and proper rate. Speaking of rate, during CPR, when there's no advanced airway in place, no endotracheal tube or ETC, combi tube, when there's no advanced airway in place, we're going to do 30 compressions, and then we're going to pause for 2 ventilations with bag valve mask. Any other time, when we are not doing CPR, or when we do have an advanced airway in place, any other time, we're going to give breaths at a rate of 10 to 12 per minute, so essentially once every 5 seconds. So you ventilate, you count to 5, you ventilate again. Mask seal is the key with bag mask ventilation. Until we've started ventilating to a tube of some sort, the mask is key. And we believe the bag mask is a two-person tool. And so the picture at the top very clearly shows one person maintaining mask seal and airway position, and the other person ventilating. In the case of CPR, we would like to have the compressor do the 30 compressions and then reach over and squeeze the bag. So the person managing the airway and doing the mask seal is only worried with the airway and the mask seal, and the second person is either compressing the chest or compressing the bag valve mask. And the bottom right shows a one-handed technique that's exceedingly difficult to do. Perhaps in small patients, if you have very large hands, you have a chance at that. Usually your mask seal is what suffers, and it's difficult to keep that airway position. And so for that reason, we have not abandoned the pocket mask. The pocket mask is still a very valuable tool, and we would be interested in proper volume over and above supplemental oxygen. So if we have to make a trade-off there, we're going to trade off for volume. And that pocket mask does an excellent job of that. It allows you to use both of your hands to do the mask seal and maintain the airway, and then give the volume with your lungs. You can also supplement that, of course, with an O2 tubing or a nasal cannula in the patient's nose, cranked up to 15 liters or so. So let's don't abandon the pocket mask. It's still a legitimate tool for us, especially if we're short-handed. But whenever possible, we believe the bag valve mask is the best, with supplemental O2 at 15 liters unless we're pre-oxygenating, and 25 if we're doing pre-oxygenation, and make that a two-person tool. So in summary, ventilation: smooth, low-pressure ventilations that produce a normal chest rise, delivered about once every 5 or 6 seconds, or 10 times a minute. That's the standard. That's what we're looking for. And that's what we're trying to do when there's no CPR going on. When we are doing CPR and there's no advanced airway in place yet, no combi tube or ET tube in place, we're still going to do smooth, low-pressure ventilations with a normal chest rise, but the compressor will do 30 chest compressions and then deliver those 2 breaths during the pause. Once we have an advanced airway in place, either an endotracheal tube or esophageal tracheal combi tube, the ETC combi tube, once we have an advanced airway in place, then we should switch. It's not an option. We should switch to continuous compressions, no pauses, and we should then ventilate once every 5 to 6 seconds. When that advanced airway is in place, it allows us to get the breath in without the need to pause during compressions. So smooth, low-pressure ventilations, normal chest rise every 5 to 6 seconds, identical to what you would do if there was no CPR going on. And this is an important thing for us to work with.